Okay. So today I'll discuss around 15, 20 to 21 questions around some basic concepts and which have been repeatedly asked in your previous exams. Based on that, I have framed some questions. So let us kickstart for today. The first is a 45-year-old male presented to the ER with acute onset right upper quadrant pain and fever for 1 day. So he was diagnosed of acute cholecystitis. So he is now admitted and then he underwent laparoscopic cholecystectomy. Intraoperative dense adhesions around the gallbladder is noted. So what class of wound does this come under? So classification of wounds. This is a repeatedly asked question in your NEET-PG as well as INI-CET, but NEET-PG, this is a very important topic. Okay, so this question is acute cholecystitis undergoing lap cholecystectomy. So what is the class of wound? It is not class 1. It is not class 4 for sure. Yes, it is class 3. So in acute inflammation, if it is performed both cholecystectomy and appendicectomy, this will come under class 3. But if interval cholecystectomy or interval appendicectomy is performed, it will come under class 2. Please don't make mistakes in this very, very important topic for your examination. So class 3 contaminated. So class 1 is uninfected operative wounds. So there is no inflammation is encountered. You don't enter the respiratory tract, alimentary tract, or the genital tract. So for example, it should be hernia, that is uncomplicated hernia, breast and thyroid. Very simple, easy to remember. Then class 2 is respiratory, alimentary, and genital tract are opened under controlled conditions. So which means inflammation is not there. I told you interval cholecystectomy, interval appendicectomy. Then you have to remember you do surgery in prepared bowel. So gastrectomy is performed after preparing the bowel, elective gastrectomy resection procedures. In class 3 contaminated, you open it, so it is coming under inflammation. Then for example, if the case scenario they give you, it is a case of interval cholecystectomy, but during cholecystectomy you rupture the gallbladder and bile gets spilled into the abdomen. What does this class of wound come? Then you have to mark as 3, class 3 contaminated, because accidentally you open the gallbladder and the bile gets spilled into the peritoneal cavity. So that will come under class 3. And remember, open cardiac massage is also a class 3 wound. And when you open bowel, in case of obstruction, that is the bowel is unprepared. This emergency conditions. So on opening the bowel, there will be some spillage of the contents, either bile or fecal content. Then it will be coming under class 3. Class 4 is dirty, that is old traumatic wounds or already perforated viscera, that is bowel perforation. Or, yeah, always in emergency, nowadays, either emergency or elective, it is the procedure of choice is laparoscopic cholecystectomy only. Open cholecystectomy is very, very rare. Only if lap cholecystectomy gets failed or you're not able to complete it fully, you convert it into open. Okay, within 48 hours, you can do cholecystectomy. Only after 78 hours, the adhesions start to ensure, then it will be difficult to perform a lap cholecystectomy. Okay. So bowel perforation. And one more point is when there is old traumatic wounds more than 6 hours for debridement. All these will come under dirty wounds. Next, this is a very important rule. According to Weigert-Meyer rule, interval tonsillectomy. Here you are opening the alimentary tract only, but under controlled conditions. So it will come under class 2. Next, according to Weigert-Meyer rule, this is for duplex ureter, duplicated ureter. So which of the following is true statement? If anyone can answer, you can answer. Then I will discuss the diagram that is given in Bailey, then come to this discussion of this. The upper pole ureter inserts laterally and superiorly into the bladder. The upper pole ureter has an associated ureterocele. The lower pole ureter is the ectopic ureter, or there is PUG obstruction is more common with lower pole ureter. This is a little bit difficult question. So think and answer. No, A is not right. All are giving unknown options. Okay, I think many people are getting it wrong. But I'll go to the discussion, just don't get confused. I'll tell you in a very easy manner for the exam. Okay. So this is the diagram that is given in Bailey, very important diagram. Okay. So you remember lower pole ureter is the normal ureter. Lower pole ureter is the normal ureter, and upper pole ureter is the ectopic or duplex ureter. Upper pole ureter is the ectopic ureter. So this is the dysplastic ureter or the other useless ureter, which means it is not functioning at all. Lower pole ureter is the normal ureter, which is draining the kidney. So this lower pole ureter will insert normally only. Okay, it will insert to the normal position of the bladder. But this upper pole ureter will always join. It will be joining inferiorly and medially. Very important point. Inferiorly and medially into the bladder. Okay, the upper pole ureter will drain inferiorly and medially. See, this is the normal the position for the ureter gets connected to the bladder, but the upper pole ureter will be joining inferiorly and medially, and they will be having ureterocele. Remember this, upper pole ureter will be having ureterocele. But this lower pole ureter, I told you, it will be joining normally, but they will be having a short mucosal tunnel. Short submucosal tunnel. So what is the significance of this is they will be having VUR, vesico-ureteric reflex. So the lower pole ureter draining ureter having vesico-ureteric reflex. This is an important point. The upper pole ureter is the ectopic ureter and it is having ureterocele. Lower pole ureter will be inserting normal into the bladder but having a short submucosal tunnel. There should be adequate length of the ureter within the bladder to prevent the reflux of the urine into the bladder. Okay. So if there is a very short submucosal tunnel, there will be excess reflex that is called vesico-ureteric reflex. And this lower pole ureter only also has pelvic-ureteric junction obstruction. So lower pole ureter has VUR as well as PUG obstruction. Upper pole ureter is the ectopic one and it has ureterocele. Okay, remember for your exams. So here the answer should be the upper pole ureter will insert inferiorly and medially. So this is false. The upper pole ureter has an associated ureterocele, wrong. Sorry, the upper pole ureter has the ureterocele, right? Yeah. Actually, two answers are right here. Okay, the lower pole ureter is the ectopic ureter is the wrong statement. Okay. Pelvic-ureteric junction is also common with lower pole ureter. So two answers are right here. Okay. Upper pole ureter, ectopic ureter has ureterocele, and the lower pole ureter has both vesico-ureteric reflex and PUG obstruction. Okay. So both B and D are right here. Sorry for the confusion. Both B and D are right. And one more thing you remember, this upper pole ureter, that is ectopic ureter, always in males it will be joining above the external urethral sphincter, so it will be always continent. But in females it will always come below the external urethral sphincter. So that is why the female babies will be voiding normally also and also have dribbling of urine in between. Okay, remember this point. Males always above the external urethral sphincter, but in females it is below the external urethral sphincter. Because below the external urethral sphincter means there will be continuous dribbling also, and the bladder also will get filled up, and there will be normal voiding also. Okay, incontinence will be there. Next, a 60-year-old male comes to the OPD with complaints of bleeding PR for 4 months and passing mucus mixed stools early morning. So all these are classical symptoms of some obstruction or growth in the rectum. Early morning furious diarrhea, bleeding PR. He gives history of hemorrhoidectomy 2 months back, but the complaint is still persisting. Sigmoidoscopy reveals a ulcero-proliferative growth about 8 centimeters from the anal verge. For the demonstrations, local growth only without any metastasis. So well-differentiated adenocarcinoma. It is low anterior resection only. The answer is right, low anterior resection. So always remember, in cases of bleeding PR, never forget to do a proctoscopy or a complete sigmoidoscopy before you operate for hemorrhoidectomy. The rectal growth, the anal growth will be presenting as a hemorrhoid also. So that is what this patient was messed up in the previous surgery itself. So it is a low anterior section. So the growth is about 8 centimeters from the anal verge. What will be the proximal margin of resection? The proximal margin will be 5 centimeter and distal margin is 2 centimeter. But in ultra low anterior resection, even 1 centimeter margin can be given. That is why it is called ultra low anterior resection, where you perform a coloanal anastomosis. Here 8 centimeter means there will be at least 6 centimeter from the anal verge. So you can perform a colorectal anastomosis itself. So abdominal perineal resection, when can be performed? APRs. When it involves anal canal. Sphincters are involved. Okay, APR will be done. It involves the anal canal itself, and when the sphincters are involved. These are two important points. So APR, when you can do only when the anal canal is involved and the sphincters also are involved. Otherwise, low anterior resection, ultra low anterior resection can be done. So Hartmann surgery followed by chemotherapy is when the patient is presenting to with obstruction in emergency. So in emergency conditions, when the patient is presenting obstruction, dilated bowel loops, you will not be able to perform resection anastomosis. So Hartmann surgery will be done. Then you can give chemotherapy, then reduce the size of the growth, and then go for definitive procedure later. Next, which of the following is false regarding OPSI? Overwhelming post-splenectomy infection. So it occurs most commonly following splenectomy for hematological conditions. This is true. And the most common organism involved is Streptococcus pneumoniae. This is also true. And vaccination to be given 2 weeks prior to elective splenectomy. This is also true. So it occurs 2 to 3 years after splenectomy, not within 1 year. Okay, 2 to 3 years after splenectomy. So what are the things that is important in OPSI is it will occur 2 to 3 years after splenectomy. What are the organisms that are involved? Streptococcus pneumoniae, Neisseria meningitis, and H. influenzae B. Okay. So what is the when do you give vaccination in elective cases? 2 weeks prior to surgery. And emergency, when do you give? More than 10 days. That is when the post-operative day 10 has come, or at the time of delivery. Sorry, discharge. Okay. On 10 days or at the time of discharge, whichever is earlier. Then they will ask you what are the most common complications of splenectomy. Most common complication is left lower lobe atelectasis. Okay, remember this left lower lobe atelectasis. Why does this happen is you perform surgery below the left diaphragm, so the patient will have pain in the subdiaphragmatic area, so he will not be able to breathe very well. So the left lower lobe will go for collapse, going for atelectasis. So when you don't give adequate respirometer, that is breathing exercise, chest physiotherapy, the atelectasis will go for pneumonia or consolidation. So remember this early complication is atelectasis. If you don't treat atelectasis properly, it will go for pneumonia. Then one more important complication is post-splenectomy, there will be thrombocytosis. Okay, very important point. Post-splenectomy, there will be thrombocytosis because the platelet is the spleen is the place where the platelets get destroyed. But after removing the spleen, the platelet counts gets increased in the periphery. So immediate post-operative period, there will be thrombocytosis, and then it will get corrected by itself. So in this post-operative period, you have to give prophylactic aspirin to all patients. So these are some important points regarding the post-splenectomy complications. Next, a 30-year-old patient recently diagnosed hypertensive on 3 antihypertensives. So remember this point. If the patient is not getting controlled with hypertension medications, think about adrenal causes. Important surgery wise, adrenal causes are very important. So ultrasound don't reveal the mass in the adrenal. Then you do a urinary VMA, vanillin mandelic acid. The levels are elevated. So you suspect pheochromocytoma. So what will be your next step in the management? From these options given, all are getting it right. Very good. So FNAC is always contraindicated. Okay, FNAC never should be done in a case of pheochromocytoma. You will go in for release of all the adrenaline and noradrenaline into the bloodstream, and the patient end up in shock. So laparoscopic adrenalectomy can be done, but before that, it is always pre-treatment with alpha blockers. After you achieve alpha blockade, then you give beta blockade also, and then you go for surgery. Okay, NEETPG scan is only for ectopic sites, that is paraganglionomas. But before this, you always do MRI abdomen, not CECT abdomen. And anyone tell why CECT is not preferred in pheochromocytoma? Contrast. It's not contrast nephropathy. Contrast will stimulate the pheochromocytoma to release the hormones. So you avoid it. Yeah, hypertension crisis only. Okay. You do MRI abdomen, then you can go for laparoscopy adrenalectomy. Okay. So pre-treatment with alpha blockers. Phenoxybenzamine, then give beta blockade. Then a patient of Crohn's disease underwent resection anastomosis. On postoperative day 7, he presented with anastomotic leak. So now we are discussing a case of enterocutaneous fistula. So daily output is 150 ml per day. There is no signs of sepsis and no intra-abdominal collection also. Patient is vitally stable now. What will be the next line of management? These are all clinically based questions which I have framed. So think and answer. Simple questions only. You're very strong actually. So you need not go for laparotomy. That is the main point from this question. So laparotomy is not needed because the patient is now vitally stable. Okay. So you can continually conservative management and hope for spontaneous resolution. Rigorous resuscitation ICU is also not needed. Okay. So I'll tell you. So according to the SNAP protocol, S is for sepsis control and skincare. Then this is for nutrition. If the patient is not able to take it orally, you give parental nutrition, total parental nutrition, TPN. Then you go for anatomical delineation. Then the definitive procedure will be performed after 4 to 6 weeks. So the output, based on the output, it can be classified into low output, intermediate, and high output fistulas. So low is less than 150, high is more than 500 ml per day. and this is 150 to 500 ml per day. Okay, so in high output, very vigorous resuscitation is needed because there will be electrolyte imbalances. So in high output, you always cannot wait for it to spontaneously close. It is very, very difficult for the output to close by itself. But low output, you can wait for minimum of 2 months also, 1.5 months to 2 months you can wait. It will completely close by itself. And just I'll revise that friends protocol. So which are the things that will close? F is foreign body, it will not close. If there is any foreign body within the tract, it will not close. R is radiation. I is immunosuppression. IBD, inflammatory bowel disease. E is epithelialized tract. N is poor nutrition. D is distal obstruction. And S is sepsis. Okay, all if these are present, you cannot expect the fistula to close. And one more question, whether long fistulas will close or short fistulas will close. Yeah, long fistula will close easily. Okay, but short fistula is only a small wide opening will be there, so it will not easily close. These are important points. Next, this is a case of pancreatitis. Acute severe necrotizing pancreatitis and suddenly develops tachypnea and respiratory distress. O2 support is given and you perform a chest X-ray. What is your provisional diagnosis from this? We all are getting it right. Baby. This acute respiratory distress syndrome because dense intense inflammatory infiltrate is present in both the quadrants or both the lungs. Okay. Pleural effusion, it will be obliterating from the cardiophrenic angle and there will be collection like this. Pulmonary embolism will not be presenting in pancreatitis at all. It is very, very rare to develop pulmonary embolism. Atelectasis, there should be completely wiped out lung here. That is collapse of the lung. So what are the complications of acute pancreatitis? So only one thing you have to remember here is pleural effusion will come under local complications. Remember, in acute pancreatitis, pleural effusion and ascites all will come under local complications. Okay? So peripancreatic fluid collection, necrosis, infected necrosis, pancreatic abscess, pseudocyst, splenic vein thrombosis, and splenic artery aneurysms. All these are local complications. Only where you will make mistake is pleural effusion, ascites will think as a systemic complication, but it is a local complication only because the pancreatitis secretes fluid and this fluid gets sequestered. So it is a local complication of the pancreas. Then systemic is you go for shock, ARDS, renal failure, DIC, and metabolic complications. So hypocalcemia is a very, very important point in pancreatitis. And the insulin will not be secreted properly, so hyperglycemia and hyperlipidemia. So because of the intense inflammation within the abdomen, there will be paralytic ileus also. Then other things are not much important. These are the important complications in acute pancreatitis. So in this very important, you have to revise Atlanta classification. Then pseudocyst DEGDOS classification also you remember, revise and go. Then which are the etiological risk factors for pancreatitis? So acute pancreatitis overall it is always gallstones only. Okay, only in chronic pancreatitis it is alcohol, but acute pancreatitis in males it is alcohol. Next, urethral injury repeatedly asked in your exams. So young male presents to the ER following RTA, pelvic fracture and has not passed urine since the incident. So on examination, blood is noted in the Mediators. So it is always a mostly urethral injury. So everyone are getting it right. All are very strong in these concepts. So retrograde urethrogram image is shown below, shows the disruption of the urethra here. This membranous urethra. Everyone are getting it right. Very good. So these are the different parts of the urethra. One is prostatic urethra. This is membranous. This is bulbar, and this is the pineal urethra. Most common is also membranous urethra only. Okay. Next, a 10-year-old boy presents to the OPD with the left scrotal sac empty. On examination, the right testis was normally placed in the scrotum, and the left testis was found in the femoral canal. What is the most likely diagnosis? Please think and answer. Don't get it in a haste or quickly. Few people are getting it right. The answer is C here. Okay, ectopic testis. So how do you differentiate undescended and ectopic testis? The undescended testis will be present in the normal path of descent. Okay. The femoral canal is not a normal path of descent. Ectopic testis is not in the normal pathway. So this is the normal pathway of descent. First it will be in intra-abdominally, then it will come to the superficial inguinal ring, deep inguinal ring into the inguinal canal and the deep superficial inguinal ring and then into the scrotum like this. Okay, so this is the normal pathway. But what are the abnormal paths or where it can get dislodged? That is the superficial ectopic pouch, inguinal pouch, then femoral pouch. This is the prepenile and then the transverse scrotal also. Okay, these are abnormal pathways. So these are called ectopic sites. So how do you differentiate a undescended testis from a retractile testis? Undescended testis means the testis has not descended itself. So the scrotum will be completely not developed and there won't be any rugae also. That scrotal site will be completely empty. But in retractile testis, the scrotum will be developed. And after the testis has come down, the testis is getting back inside and then it will come back again. So that is called retractile testis. Yeah, occasional jump and scrotum is developed. Very good. So ectopic testis is done. So a newborn child was brought to the pediatric OPD, found to have combined cleft lip and palate. What is the ideal age group for surgical correction of soft palate? Yeah, everyone are getting it right. The answer is 6 months. So just remember, if it is a unilateral cleft lip alone, just remember 5 to 6 months. Okay. For lip, it is 5 to 6 months. Soft palate is 6 months. Hard palate, you can do it at 15 to 18 months. So when there is a combined cleft lip and palate, you can combine the cleft lip and soft palate at the 6 months itself. Okay, this is also 6 months. This is also 6 months. You can do single setting for both the surgeries. And for hard palate, you can wait till 15 to 18 months and do the hard palate. So this is very important. It is 6 months. Remember this. Okay. Very good. Then 35-year-old male comes to the ER with sudden onset severe epigastric pain and vomiting since morning. No, just for adequate development to happen. Then only you can mobilize the tissues. That is why, nothing else. Then his last episode, 2 days back, evaluation is tachypneic and tachycardia. TLC is elevated. Which of the following scoring systems are not used? Why are you everyone saying Ranson's? And now only everyone is getting it right. Getting it right. So it is Nottingham score. Okay. Ranson score is in pancreatitis. Marshall score is also for pancreatitis. CRP value also has a prognostic significance in pancreas. So more than 150 value is considered severe pancreatitis. Okay. You need not remember each and everything. That is, what are the points in Ranson's? It is just difference for both gallstone and non-gallstone pancreatitis. Marshall score, you can just remember pancreatitis. You need not remember the parameters one by one. Okay. Nottingham score is used in breast proportion, breast CA and DCIS. It is Nottingham's prognostic index only. Okay. Nottingham's prognostic index. That is size. What are the things that are involved alone? You remember size of the tumor, lymph nodes, and grade of the tumor. That is well differentiated, low grade, middle, intermediate grade, or high grade. Just remember that alone. You need not remember these values. Just remember what are the things that are included in Nottingham score alone. Next, This is a nice question. So, 47-year-old female referred to the surgical team with a cystic lesion of size 5 cm in the body of pancreas, found during the evaluation of pancreatitis. So, fluid analysis shows low amylase but high CEA levels. So, each and everything you have to get into the answer when you get the answer. One is age, then females, then which part of the pancreas, and these values. Then you come to the diagnosis. Good DNA. Why both are B, comma A? It is actually B only, mucinous cystic neoplasm. Okay. Okay, the second one, resection. Yeah, that's right. So mucinous cystic neoplasm, the age will be perimenopausal. Most common will affect the body of pancreas. Okay, and low amylase and high CEA levels. But in serous cystic neoplasm, there will be low amylase as well as low CEA levels. Okay. In IPMN, amylase is also will be more and CEA levels also will be more. Pseudocyst can occur from any part of the body. There were amylase levels, depending whether it is acute pancreatitis or chronic pancreatitis, levels will be different. CA levels will be completely normal in pseudocyst. So, for mucinous cystic neoplasm, always resection. Whatever the size it might be, you have to do resection only. You cannot put the patient under surveillance. The important points is, it is perimenopausal, I told you, females. Then you remember peripheral calcifications. CT will show peripheral calcifications. Then high viscosity, CEA elevated, and low amylase. This is important and potentially malignant. So you have to resect only. Okay. No, you cannot wait. Only resection is important. IXL calcifications. Next, I'll discuss serous and IPMN also. One is serous cystic neoplasm. Here also females are common, but age group is elderly. Okay. And this important is central stellate scar and honeycomb pattern. CT finding honeycomb and central stellate scar. Here all are low CEA, low amylase, low viscosity. So here you can put the patient under surveillance. Okay, surveillance is enough. But IPMN, it is equal, both males and females. Fishmouth deformity, then Ohashi triad. Okay. So here it can be from a main duct or it can come from a branch duct. Here all are elevated. So it is always potentially malignant and you have to do resection. Next. A 60-year-old presents to ER with features of acute cholecystitis. On examination, there is fever, severe tenderness in the right hypochondrium. So suggestive of acute cholecystitis, then conservatively in ICU. Okay. Then he develops signs of sepsis and peritonitis. What is the grading of cholecystitis? This is based on Tokyo consensus guidelines. From the edition of PD only. I know because everyone think about sepsis and peritonitis. Will go towards C. So C is wrong actually. Okay, now coming to this important part. So in this grade 2, grade 1 is nothing, only just a simple cholecystitis and you will be able to perform cholecystectomy very easily. See, sepsis, WBC count elevated, palpable tender mass, duration 78 hours, and biliary peritonitis will be coming under moderate. Okay, only organ dysfunction that will be considered as severe. Remember this. So cardiovascular means you can just remember easily, that is decreased BP. Neurological means consciousness reduced. Respiratory system not maintaining SpO2. Renal dysfunction is creatinine getting elevated. Hepatic dysfunction, remember PTINR getting deranged. Don't need to remember the values, just remember PTINR deranged. Hematological is platelet count is less than 1 lakh. Thrombocytopenia. Okay. So only when there is organ dysfunction, it will come under severe. Otherwise, local complications, whatever local complication it can be, gangrenous cholecystitis, cholecystic abscess, emphysematous cholecystitis, biliary peritonitis, that is going in for perforation and causing biliary peritonitis, all will come under moderate only. Okay. So the answer should be moderate here, not severe. And moderately severe is not at all in cholecystitis. Moderately severe will come in Atlanta classification of pancreatitis. So mild is, I told you, only a simple cholecystitis. The patient will be completely fine. You can do a emergency cholecystectomy without any difficulty. So again, remember this, local complications will come under moderate and systemic organ dysfunction only will come under severe. Which of the following is not a sign related to volume overload in surgical patients? So fluid management is very important. Revise those fluid management, TPN, enteral nutrition, what are the advantages and disadvantages, complications, you revise it and go. So sign related to volume overload, not. So when there is volume overload, peripheral edema will be there. Huh? Why everyone are going in for B? See, edema, if it is present in the periphery, bowel also will go in for edema, volume overload. Undescended neck veins is sign of volume overload. So answer is azotemia, means there is a decreased kidney output going in for rise of creatinine values. That is called azotemia. C is the right answer. So which are the volume excesses? First sign is always weight gain only. The patient will start gaining weight. Then peripheral edema. Then cardiac output increases, distended neck veins. Then bowel edema and pulmonary edema, all are increased volume. So volume deficit means you're not giving adequate volume support. So weight loss will be there, decreased skin turgor, that is pinchability will be not there, and tachycardia. Then hypotension, tachycardia will be there. Then collapsed neck veins, polyuria, azotemia, and the bowel will go for ileus in this. If you're not giving adequate fluids, the bowel will go for paralytic ileus only. Bowel edema will be there in giving volume overload. So in post-operative period of bowel resection anastomosis, fluid volume should be adequate. You have to prevent hypotension. Otherwise, if you give more fluids, bowel edema will happen and there will go for anastomotic leakage. Okay. Next, inflammatory. Which of the following is anti-inflammatory mediator of shock? Pro-inflammatory, anti-inflammatory, very important. And the hormones that are mediating those response, revise those also. This is a straightforward question only. TNF, interferon, or interleukin are pro-inflammatory. And A is the right answer, TGF beta, transforming growth factor beta. So interleukin 4, 10 and 13, just remember these three. That will come under anti-inflammatory and TGF beta. So pro-inflammatory is 1 alpha, 2, 6, 8. So you can remember this 4, 10, 13 alone, remember. Interferon, TNF, all these are come under pro-inflammatory cytokines. All these are taken directly from Bailey, Saveston, the basic surgical textbooks only. So all references have been attached with this. Next, a 45-year-old male patient comes to the ER following blunt trauma abdomen 2 hours back. So this is based on the class of shock. So examination is anxious, BP is 100/70 and heart rate is 110. So mild dyspnea is noted. Which class of shock? Don't make mistake. Option A is never the right answer. I thought people will get confused between B and C, but people are very clear. B is the right answer. Okay. So anxious, BP 100/70 is normal only. Okay. Only when it is falling, it will come under class 3. Tachycardia will be there, more than 100 is class 2. These are all class 2. And mild dyspnea will be there. Okay, all these are coming under class 2. So class 2 is mildly anxious, more than 100, BP will be normal, and mild tachypnea will be there. Okay, these are the important points here. So anxious or confused, more than 120, BP falling will come under class 3. In this table is a very, very important table. Please revise for the exam and go. Very important table. Based on the class of shock. Okay. Next, which of the following is not a type of obstructive type of shock? Tension pneumothorax is obstructive type. Pulmonary embolus is obstructive type. Gravid uterus also causing obstruction. But spinal cord neoplasm will go for neurogenic or spinal shock. Okay. So, causes of obstructive shock. One is pericardial tamponade, pulmonary embolus, tension pneumothorax, IVC obstruction, all types of IVC obstruction. In this gravid uterus coming, DVT is there, neoplasm. So, and increased intrathoracic pressure where the causing compression over the IVC. So, all these are going in for obstructive type of shock. And this is also very important tabular column, which is from this multiple questions have been asked. So, hypovolemic shock, the volume cardiac output itself will be low only. Yeah, tension pneumothorax also. Tension pneumothorax also will cause compression, and there won't be any easy to any closed tension. What is closed tension? So I'll discuss at the end, and then we will discuss at the end. Okay. So in hypovolemic, the volume itself is low, so cardiac output is low. And cardiogenic, the volume is also low. It is okay. Obstructive also, there is reduced volume. So volume will be low, cardiac output, but distributive, the volume will be high because the heart will be thinking that it is not able to supply properly. So it will be pumping more blood. So cardiac output will be high here. And remember, in distributive shock only, mixed venous oxygen saturation. What is MVO2 is, so when the heart is pumping, the oxygen will be given to the tissues. And only a small amount will come back to the heart. But in distributive shock, this is not taken up by the tissues. Okay, due to some sepsis or due to some cause, it is not able to taken up by the tissue. So return also the O2 will be high. That is why in the distributive shock, the mixed venous oxygen saturation is high. So cardiac output and these are inversely proportional. Okay. Base deficit will be high in all the four. So venous pressure will be high only in cardiogenic shock and obstructive shock. Why? Cardiogenic heart is not pumping adequately, so venous pressure is building up. In obstructive shock also, the blood is not coming to the heart properly, so the venous pressure will be high. Otherwise, all these type of shock, venous pressure will be low only. So this is a very important tabular column. We have to revise for the exam. Very important tabular column. Next, sustain a stab injury to the abdomen. The sharp knife after clash with his wife. He is rushed to the ER with the knife in situ. He is wincing in pain and he is confused. On examination, he is tachycardia, tachypneic, BP is low. Which of the following is not done in your initial assessment? Okay, multiple right answers. So one is right, the other one, yeah, it is CC the abdomen and not remove the knife. Very, very important point. You should never remove the knife in the emergency room. You always have to take the patient for laparotomy in the OT after everything is stabilized, airway, breathing, circulation. Then only you have to take out the knife, and there should be adequate control because it might injure the aorta or IVC. So when you take out the knife, the bleeding will start coming profusely. Okay. So this has to be done only when there is adequate proximal and distal control. So if it is a bleeding from aorta or IVC, you have to establish both proximal and distal venous control. Then take out the knife and then suture it. So very, very important, never take out the knife. So first you have to do IV lines has to be done. This is true statement. Prepare for laparotomy also true statement. And E first also can be done. Okay. Yeah, E first done only for blunt trauma. But in this question, it can be get done. Fast is only for traumatic cases. Next, if the patient comes with stab wound, if there is shock, peritonitis, evisceration, hemodynamic instability, free air under chest X-ray, all goes for laparotomy directly. Okay. And now coming to the location of injury. So anterior abdomen can, if all these are present, you go for direct laparotomy. So now if these will come under only stable patients. So anterior abdomen means you can do CT abdomen. Then serial abdominal exams can be done. So sometimes there will be only breach up to the peritoneum, otherwise not deep. So if there is a breach in the peritoneum itself, you have to go for laparotomy only. Facial violation or there is peritonitis, always go for a laparotomy. So negative meaning the patient has no breach, the vitals are stable, serial examination also abdomen is completely soft, then you can go for conservative management. So plank or bag meaning it is going for kidney injury mostly. So always first do CT scan, rectal contrast, then do laparotomy if indicated, otherwise laparotomy is not needed. So thoracoabdomen meaning at the site of diaphragm. So always you have to do evaluation of diaphragm. So diaphragmatic injury is there. How will you repair, whether intra-abdominally or through the thoracic route? Diaphragmatic injury always operate through the abdominal route only. Okay, never through the thoracic route. Next, 70-year-old female comes to OPD for consultation after she underwent laparoscopic appendicectomy for acute appendicitis 10 days back. So the biopsy report shows a carcinoid tumor of size 1.57 centimeter arising in the tip of appendix, LV negative, very close margins, no mesoappendix involvement. What will be your further management? In appendix, this is one favorite topic for the examination. So A and B is going for equal competition. Surveillance, right hemicolectomy. But the winner here is right hemicolectomy only. Okay. See, one thing is if the size is more than 2 centimeter, always right hemicolectomy. 1 to 2 centimeter, you have to look for other options. So where is the site? So if it is base of the appendix, right hemicolectomy you have to do. Then lymphovascular invasion present, you have to go for appendicectomy. Then mesoappendix involvement, you have to go for right hemicolectomy. And margin should be adequate, not very close margins. Very close margins are positive margins. You have to go for right hemicolectomy. Only less than 1 centimeter or tip of the appendix, then you can do surveillance. Okay, and the same question if they say you 1.7 centimeter adenocarcinoma, all these are normal, no margins, everything. What will be the treatment? This is for carcinoid tumors. So adenocarcinoma, whatever the size it might be, 1 centimeter, 2 centimeter, whatever it is always right hemicolectomy. Okay. So answer is right hemicolectomy here. So this is not going to remember this entire, whatever I told you, that is enough for your exam. So appendicular neoplasm, less than 1 centimeter observation, more than 2 centimeter, I told you right hemicolectomy. So 1 to 2 centimeter, you have to look for the other components. If yes, then right hemicolectomy. If no, go for observation. But if it is adenocarcinoma, size, anything doesn't matter. Only right hemicolectomy has to be done. Okay. And this is appendiceal mucinous neoplasm. This remember this alone. So if it is a low grade appendiceal mucinous neoplasm, okay, margin is positive, base is present, mesoappendix also involved, then right hemicolectomy has to be done. If no, then appendicectomy is sufficient. But if it is a disseminated peritoneal adenomyocinosis or peritoneal mucinous carcinomatosis, then you have to do a CRS HIPEC, that is cytoreductive surgery. Cytoreductive surgery plus HIPEC. HIPEC is hyperthermic intraperitoneal chemotherapy. So this is incidental tumor detected operation, then you can do what based on these points itself. But after appendicectomy, just remember this. This will not be asked in your exam, but only this will be asked in your exams. Okay. Next, a 40-year-old female comes to the ER with symptoms of signs of acute bowel obstruction. It also gives multiple history of cholecystitis. The X-ray abdomen is shown below. Which of the following is not included in the management of this patient? So this has multiple meaning. It is not a straightforward question. I have marked this. So what is this diagnosis? Yeah, it is Gallstone Ileus. Okay, it is Gallstone Ileus. So this stone is found here. Regular striate Gallstone Ileus. So in this case, you have to do laparotomy because the patient is in obstruction. You have to do cholecystectomy for removal of the gallstone, and this stone also has to be removed. And closure of fistula is not needed in this. Okay, this is the answer here. When it is a complete formed fistula, you need not disturb the fistula. You can just leave it off. So if this is the bowel, this is proximal, this is distal, and the stone is getting occluded here. Where will you put the incision and how will you take the stone? Incision always proximal to it, not distally. Never distally. Okay, incision has to be given proximally here. Then milk out this stone through this opening and close this enterotomy. Okay. This closure of fistula never needed. So when someone asks me what is closed, tension pneumothorax. See, closed pneumothorax meaning the pleura gets injured and from which it is causing pneumothorax. That is a normal pneumothorax which we encounter. That is a tension pneumothorax. Open pneumothorax is there is some external injury, and through this injury, the air is getting into the pleural cavity, and the air doesn't come out. So if the air is keeping on getting trapped inside, this open pneumothorax also will go for tension pneumothorax. So the component here is tension pneumothorax that is causing the lung parenchyma to get obstructed. So always it is the same only. It will go on for obstructive kind of shock only. Okay, closed or open doesn't matter here. So important topics that you have to revise for the exam is TNM of breast is very important. GCS never make mistake in the Glasgow coma score. Then shock I discussed already. Then wound is very important. Trauma, all kinds of trauma. Tension pneumothorax. Where do you put the needle decompression? What is the safety triangle? All these are important questions. Then bile duct injuries. I don't know why this bile duct injury is keeping on coming to my mind this time. Maybe you'll get a question. We'll see. Plasma classification. So please revise all these topics. Very important for your exams. So whatever is new or updated, I have covered everything. So just connect to my question once again. So splenectomy, I told you, OPSI is mostly after 2 to 3 years after splenectomy. It doesn't come within 1 year. The organisms that are involved are Streptococcus pneumoniae, Neisseria meningitis, and H. influenza type B. All these are capsulated organisms. In elective, you have to do 2 weeks prior. I'll tell you. So elective is 2 weeks prior. Then emergency is more than 10 days or at the time of discharge. Then most common complication is left lower lobe atelectasis only. So immediately in the post-operative period, the patient will not be able to breathe properly. So the left lower lobe will go for atelectasis. So if you don't manage it adequately, so how do you treat atelectasis? You ask the patient to respire or breathe properly, use spirometry, incentive spirometry, breathing exercises, chest physiotherapy. All this has to be done. So if they do these things properly, the atelectasis will get corrected. But if the atelectasis goes on increasing, it will go for consolidation and pneumonia. Then thrombocytosis is another complication. Thrombocytosis can go for blood clots, DVT. So you have to give prophylactic aspirin in the post-operative period. So now coming to the doubts. So more than 7 to 10 days it is given. Okay, so it is 7 or 10 days, whatever you can write. No problem. Okay, then thank you. Prepare well. All the best.